episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time, as always, to join me here, guys, to learn and to grow. I'm always so grateful for all the support, everything you do, whether it's liking, sharing, commenting, reviewing, all of that, super helpful. It's always helping us to reach more of our colleagues and help to improve our profession. And as always, I'm trying to bring on guests that can help educate us, enlighten us. I think enlighten is actually a pretty good word, especially considering the topic that we are going to be discussing today. I have the wonderful Dr. gfmerry, who is visiting us all the way from the UK. Dr. Merry graduated in medicine from the Royal London Hospital in University of London. He did his ophthalmology residency at the University of Toronto, and he has since retired from practice, but he is the founder of 3 companies that are related to photobiomodulation and eye disease. Those companies are Photospectra, Lumathera, and most recently Arunalight. So our discussion today is going to be around a very hot topic, which is red light therapy. And so Dr. Merry is going to take us through an introductory conversation of what is red light, what is photobiomodulation, how does it affect the eyes, and how can it positively affect certain eye diseases. I think this is going to be, as I said, a very enlightening conversation, and one that's very timely because I know there's a lot of discussions about this topic. So Dr. Merry, thank you so much for joining me on the podcast.
Oh, my pleasure. My pleasure. And thanks very much for the introduction.
My pleasure as well. So we're going to approach this podcast a little bit differently for our regular listeners. You know, usually what a podcast episode sounds like. But for this one, what Dr. Merry is going to do in the beginning is actually a PowerPoint presentation. So he's going to be kind of educating us a little bit for the first 15, 20 minutes or so, and then we'll jump into a bit more of a discussion after that. So if you get a chance, I would encourage you, please go watch this on YouTube, but we're going to do our best to present the information verbally, vocalize it, so you kind of can visualize in your own mind about what Dr. Merry is presenting. So let me, and with that in mind, please bear with us since this is the first time we're doing this type of a presentation on the podcast, but I am certain that we're going to be able to share the information in a way that everybody can and really absorb it. So I've pulled up the PowerPoint for you, Dr. Merry.
Thank you. Thank you.
And I'll let you jump in.
Okay. Well, I'm going to be presenting on the power of red light therapy, which is something most of you have heard about, but perhaps not aware of its mechanisms, safety, and benefits. We could just go to the next slide now. We can skip this one, I think. So photobiomodulation previously was known as low-level light therapy, and it can modify cellular behavior. Non-coherent or non-laser light sources used at low powers avoid thermal damage to the target cells. PBM can improve the functioning of compromised cells, moving them to a survival pathway. Next. It is the application of low power light of certain wavelengths to restore and improve cellular function. The mechanisms of action have been well elucidated, with the main primary effect on mitochondrial cytochrome C oxidase. There are secondary and tertiary effects that include anti-inflammatory, antioxidant, neuroprotective, and anti-apoptotic benefits. Next. PBM, well, visible light forms the narrow part of the electromagnetic spectrum, with photobiomodulation occurring between 400 to 1070 nanometers. Lower wavelengths of light are generally damaging. Think of UV and X-rays, and higher wavelengths have the beneficial properties. Next. White light consists of a range of wavelengths. For PBM, it is desirable to use specific wavelengths that are monochromatic, i.e. red. There's a very important distinction to be made here about the source of monochromatic light. Laser light is coherent, the wavelengths are all aligned, they're powerful and with a very small beam area. The energy is concentrated over this small area and has the potential to burn target cells. Lasers have been used extensively in ophthalmology to cut and cauterize tissue. The power of these devices is magnitudes higher than the devices used to photobiomodulate cells. LEDs are non-coherent with less power. They have a large beam area with a lower and much safer irradiance. Next. Photomedicine has been described for centuries. Finson won a Nobel Prize in Medicine in 1903 for his work with photomedicine. Next.
Dr. Merry, I'll just say, I think since I have the notes on my side, I could see when it's time to flip. Is that fine?
Yeah, that's great. Yeah, that's great. Yeah.
Let's just do that. It'll save you having to say next.
Okay, perfect. In the last century, there's been a great deal of interest in the development of the pharmaceutical industry. There is now re-emerging interest in PBM because of its ability to target cells directly and safely without side effects. Since the 1960s, there have been some major contributors to the field of PBM, including Mester, Pop, Carew, Wellen and Els, and in the present day, Robert Dotson and other colleagues have advanced PBM in eye care. The mechanisms of action of PBM continue to be investigated, but fall into two main areas: photobiochemical and quantum effects. Photochemical processes can occur at many locations within cells. The most elucidated evidence at present is with mitochondria, but other areas of the cell are actively being investigated and proposed as important. There is rapid development in this field to further define complex interactions within cells. There are several identified photoacceptors. Presently, the most important and best understood is cytochrome C oxidase within the mitochondria of cells. Cytochrome C oxidase is a large integral membrane protein of the mitochondria. The electron transport chain generates ATP, which is the fuel for cellular processes. I simply look at this as a free-flowing river. However, in compromised cells, there are restrictions or blocks. PBM reactivates the process of ATP production, reducing these restrictions and increasing and restoring energy production. This leads to improved ATP formation, a reduction in oxidative stress, and a reduction in inflammation, resulting in a resetting of the cellular metabolic function. Recently, it has been shown that light can affect the mitochondrial matrix viscosity mediated by intracellular melatonin and its interaction with structured water. Longer wavelengths like red cause a lower viscosity that allows the ATP turbine to increase its speed of ATP production, whereas shorter wavelengths like blue increase the viscosity and less ATP is produced. We are increasingly less exposed to red wavelengths, working indoors with lighting that is skewed towards blue wavelengths, compromising our cellular function. In addition to photochemical effects, there also appears to be an influence of cell activity through quantum field effects, which are still poorly understood. Professor Pop has researched biophotons that are emitted from living cells. These may be an important signaling factor between cells and account for some of the secondary and tertiary downstream effects of PBM. However, regardless of the precise mechanism of action, we see effects. The primary effects of mitochondrial stimulation are an increase in ATP production, which provides more energy, a decrease in reactive oxygen species, decreasing cell damage, production of nitric oxide, increasing blood flow, and regulating the immune system. There is gene upregulation of DNA and RNA synthesis, transcription factors, cytostructural proteins, and growth factors. There is gene downregulation of interleukins 1, 6, and 10, macrophage inflammatory proteins, and TNF-alpha. There is also downregulation of pro-apoptotic proteins, a significant factor in geographic atrophy. PBM has a photoceutical action. There are many light variables, including wavelength, energy density, and coherence. It also has a biphasic dose-response curve. Too little, and there's no effect. Too much negates any beneficial effects. The aim is to hit the sweet spot for the target cells. It is important that PBM parameters are defined universally and consistently used. This is especially so when reporting case studies and clinical trials. Power is given in milliwatts. Irradiance is given in watts per centimeter squared. Lasers have a higher irradiance than LEDs as they are more powerful and have a much smaller beam area. The fluence or energy density is really the dose that is delivered. This is the irradiance multiplied by the time the light is provided, and this is expressed in joules per centimeter squared. As I said, PBM has a biphasic dose-response curve following an Arndt-Schultz model. This is a 3D representation of that model. In this diagram, a combination of irradiance and time to the left of the hill peak will result in stimulation, and any combination to the right of the peak results in diminishing stimulation, and if too much for too long, the result will be inhibition. This is of vital importance in designing PBM devices to find the sweet spot for the dosage provided. This shows the relative absorption spectra of cytochrome C oxidase, along with its activity and ATP content at differing wavelengths. There is a peak absorption around 670 nanometers, which is red light, with a corresponding peak of activity and ATP content. This is one of the main reasons that so much work has been done utilizing red wavelengths around 670 nanometers.
Dr. Merry, before we move on, just for those listening, because I think this is a nice, very simple but very important graph, just to kind of verbalize it again. So the graph is showing on the x-axis.
It's the relative absorption and also there's three.
How much absorption, let's just say, and then along the y is the wavelength, the nanometers.
Exactly.
So we're starting the graph at 600 nanometers. So at 670 is the peak absorption for cytochrome oxidase, which when we go back was one of the molecules that we found was most affected by red light. So 670 seems to be the peak, and after that it drops off quite precipitously. And as you go down,
it does. And then there's another sort of little bump around about 810. And then also you can see that the ATP production is up a little bit around about the 810.
Right. So
even though the absorption spectra is down a little bit, it's still a significant wavelength, perhaps.
There is, right.
Yeah.
Got it. So 670, and sorry, what was the later one? 800?
Around about 810.
810.
810, 820.
Got it. Thank you.
Yeah. So most clinical work has been done in the areas of wound healing, especially in diabetics and dentistry. Dermatologists utilize devices to improve skin condition and reverse the aging and toxic effects of sun damage. There's been some dramatic reversal of myocardial infarction damage in deliberate coronary artery ligation in animals, with the PBM delivered remotely from the target tissue. This shows that downstream effects can benefit remote tissues. Some of the clinical applications in humans now extend to traumatic brain injuries and stroke. This slide was actually from a presentation I made in 2012, and PBM has rapidly advanced and achieved considerable gains since then. So PBM is not fiction or pseudoscience. There are proven clinical effects in healing, pain reduction, mentation, and mood, and as we will see shortly, disease-modifying effects in ophthalmology. I had the good fortune to meet Dr. Robert Dotson over 15 years ago. He's a modern-day pioneer of PBM and had been using it in his ophthalmology practice for many different conditions. We understood the significance and potential of PBM to effect a paradigm shift in the health sciences, and we co-founded Photospectra and Lumithera with a goal to achieve this. The eye is uniquely accessible to phototherapy. We have seen that PBM improves mitochondrial function. Mitochondrial dysfunction is a common feature in ocular diseases, resulting in a vicious cycle of dysfunction, oxidative damage, and cellular death. The eye has an extremely high density of mitochondria, more than any other tissue, ranging from 2 to 300 in a retinal bipolar cell to 2,000 per retinal cone cell. DARPA is the Defense Advanced Research Projects Agency. It's a US Department of Defense agency focused on developing innovative technologies, mainly for military applications. It's funded research in areas like AI, robotics, advanced materials, and has been instrumental in the development of technologies with both military and civilian uses, such as the internet. They were interested in PBM integrated into the face shield and helmet of fighter pilots to allow healed retinal function and persistence in combat from enemy high-powered laser injuries.
Yeah. That's very interesting.
Yeah. This slide is actually courtesy of Janice Ells, who's a prominent retinal researcher from the University of Wisconsin. And what this shows is the healing effect of just 4 applications of PBM following a deliberate laser grid pattern burn to a primate eye.
Wow.
The lower left panel shows obvious damage 1 month after the injury, in comparison to the LED treated eye in the lower right panel.
Wow. Can we take a second to actually, I want to go back to the pilot thing, if that's okay with you. And then I definitely want to spend a second on this slide as well. So to clarify, they put low level red light therapy into the face shield.
Yes.
So while they're flying their jet.
Well, so this. I don't know how far it went.
Oh, I see. They were testing it.
Yeah, and I'm not sure that we'd be able to find out how far it went.
Fair enough. Yeah. I'm going to assume a lot of this is
probably something to do with national security.
Absolutely. But that's such an interesting idea. So but they were looking at this, applying red light for fighter pilots.
Yes, and I think so that they could probably sort of safely land their plane and.
Yeah, of course. Wow. And so, I mean, on a similar note, then this now in a lab here, with grid laser damage done in the retina, and then there was red light therapy provided after that.
Yes, so this was a grid pattern laser, so the tissue is cauterized, and then you can see the healing effect with just 4 episodes.
Yeah, so I would encourage, again, if you're listening, go to YouTube, and there's a lot of these slides do have like really great visuals. This one's really really impactful, because you could see the on the left side, this is a monkey fundus we're looking at with the grid laser, and then a month after you can see very obvious damage, this kind of that you would expect to see. And on the right side, again, that grid laser that looks the same, but 1 month later, the damage is almost completely gone. You can't hardly see it anyway. So very significant difference.
Yeah, I would say that this slide really inspired Robert Dotson and myself to pursue PBM in ophthalmology. It's really quite a stunning slide.
It's really profound. Really, wow, excellent.
One of the conditions that does spring to mind from looking at this is that we hear of retinal solar burns from unprotected, looking at solar eclipses.
Yeah.
And I think that PBM would be beneficial in much the same way that DARPA envisaged the fighter pilots.
Seems like it. Really great. Okay.
So some work done by Dr. McDaniel with cultured human RPE cells shows some of the photo revitalization effect of 670 nanometer red light after exposure to a high power blue light. It's very similar to the previous slide with the laser burn. If you shine an intense blue light on these cells, 90% of them will die. If you shine the same blue light on these cells and then treat them with red light, only 5% of them die. So again, there was a lot of compelling evidence for us to review.
Absolutely. So again, sorry, Dr. Merry. This chart, the graph that you're showing here, as you just said, if the RPE cells were exposed to 425 nanometer blue light alone, there was 90+% cell death.
Yes.
Very damaging. But if they were exposed to that blue light and then exposed to
Red light
the photobiomodulation shortly after,
yeah,
then there was only 5% cell death. So there's a huge protective
yes.
mechanism there.
Yeah, 90% protection. Yeah.
Wow.
Yeah, so with all this research evidence that we had reviewed, we decided, that was Robert Dotton and myself, decided to instigate the Toronto and Oak Ridge trial of PBM in AMD. And we were fortunate enough to have some really open-minded, skeptical retinal specialists, Robert Devenier, Sam Markowitz, and Sophia Reyes, to help us with this. I used two devices in the study because they were available off-label. I hadn't developed my own device for this. The parameters are listed. One treatment session consisted of using each device sequentially, and this was repeated over 6 weeks for a total of 18 treatments. And the subjects were followed for 1 year and with no further intervention. And this was a very small pilot study in 18 eyes with dry AMD. And the results that we found were statistically and clinically significant improvement in contrast sensitivity and visual acuity 1 year out from treatment with no significant adverse events.
And that was with the off-label use. This was not with your own device, just using existing red light therapy out there. Yeah.
Yeah, essentially, because we hadn't got around to producing.
But again, just kind of verifying the benefits of red light in general.
Yeah, exactly. And TORPA 2 was a sort of follow-on, if you like, from TORPA 1. But the protocol differed from TORPA 1 in that the treatment was condensed to 3 weeks by doubling the dose at 9 treatment sessions instead of 18 over 6 weeks. And in fact, the results that I had from some of the early patients doing this were actually better than the 18 treatments over 6 weeks. So these inclusion criteria that we used are very similar to criteria that have been used in past ophthalmology trials. And it also gave us some indication of what we should expect and allowed us to design future clinical trials that would be robust, prospective, double-blind, and sham-controlled. I mean, this was an open-label retrospective study. Right. The results were good. Vision would increase just over 5 letters with a very significant p-value. And on the next slide, we have the analysis that was done on OCT and fundus autofluorescence scans. So TORPA 2, these were incorporated into the treatment protocol. This is what we were looking at. Whereas TORPA 1 OCT wasn't available at that time. So these were sent to an independent reading center in Bern, Switzerland, and the central Drusen volume decreased significantly immediately following the treatment with very impressive p-value, and that was maintained at a significant reduction at 3 months. And the reduction in Drusen, along with vision and contrast sensitivity improvements, was utterly compelling. And this was the first study to show visual improvement and Drusen regression in AMD with PBM. So this is a scan of a 55-year-old male just showing a marked reduction in his Drusen on these aligned scans 7 months after just 1 3-week treatment course. He also had a corresponding increase in vision and contrast sensitivity.
Yeah, again, just a great visual for those who are able to check this out on YouTube. They're very noticeable. So with the OCT scan here, quite a noticeable difference in the appearance of Drusen. That's really impressive.
Yeah, and these scans were taken with the Heidelberg Spectralis, which has a true tracking feature, so that when you're looking at a scan, it's taken in exactly the same cut as it was before and after. So the results of this TORPA-2 study were published in Acta Ophthalmologica, which is a highly rated peer-reviewed ophthalmology journal. And it was also presented internationally at a couple of conferences. This one was Retina in 2016, and Dr. Jordi Menez talked about new insights into dry AMD and PBM as a potential treatment. And here we have the inaugural World Retinal Congress with Dr. David Boyer speaking on emerging treatments for AMD. Since first publication in 2016, there have been close to 4,000 reads and over 100 citations, with a research index score that is higher than 53% of all other research related to ophthalmology. These stats are from ResearchGate, and it has been described as a landmark study by some clinicians. What I find very encouraging to see is the dramatic increase in new PBM research papers in the last 10 years. And I'm going to talk a little bit about the LIGHTSITE 3 trial, because this is a pivotal trial. And this was Lumithera's study that evaluated multi-wavelength photobiomodulation therapy in dry AMD using their Velida light delivery system. It was a randomized controlled trial.
Sorry, now, Dr. Merry, now this is a device that you actually developed.
This is a device that Lumithera developed.
Lumithera developed. So yeah. We're not just using an off-label device now, we're using one that's specifically targeting.
After TORPA-2, we looked at what was used in that and developed our own device.
Got it.
So Lumithera developed this device. And put it through rigorous clinical trials to prove this in AMD. So subjects were given multi-wavelength PBM or sham treatment delivered in a series of 9 sessions over 3 to 5 weeks, every 4 months, over 24 months. So that's a 2-year study, and the patients received treatment basically every 4 months. A total of 100 subjects, that's 148 eyes, with dry AMD were randomized. And it showed improved clinical and anatomical outcomes in intermediate dry AMD following PBM therapy. Lumithera has just announced the results from their LIGHTSITE 3B extension trial. And this showed extended 2-year pivotal trial vision benefits out to 4.5 years and showed an excellent safety profile. And this was Dr. David Boyer, who was one of the lead principal investigators, stating this. This is a representative imaging of macular drusen reduction following PBM treatment from the LIGHTSITE 3 trial. A significant reduction in macular drusen volume was observed following 4 series of PBM treatment without any loss of photoreceptor or RPE visible. A 4-letter increase in best corrected visual acuity was observed at month 13. So this is a very dramatic.
Yeah, once again. Yeah. And this was captured on?
This was the LIGHTSITE 3 trial. So I believe they were using the Heidelberg as well.
Heidelberg again. So once again, another OCT scan here just showing a dramatic reduction in drusen. And this, yeah, just again, very profound visual. So again, encourage you to check this out if you can. But as Dr. Merry just described anyway, significant reduction in drusen and an improvement from 75 letters to 79 letters, so 4-letter improvement with this therapy.
Exactly. So this successful pivotal clinical trial was the basis for gaining FDA approval. And the approval by the FDA in 2024 for using PBM in a specific eye disease is a major historic milestone in the story of PBM. This is a tremendous achievement and has recognized the validity and potential of PBM as a safe, non-invasive, and effective treatment for dry AMD. And I'm sure this is going to open the floodgates for investigating and accepting PBM in a myriad of conditions.
Yeah.
Other researchers other than Lumithera, have also shown partial reduction of Drusen volume after PBM treatment, and this time with a different device. And again, there's two patients here with before and after Drusen reductions. Again, maybe not quite as dramatic, but it's obvious.
Yep.
This is another example of dramatic improvement in a substantial pigment epithelial detachment with subretinal fluid, showing progressive flattening of the PED and absence of subretinal fluid at 3 months.
Wow. That, again, talk about very profound visuals. Holy moly. So this OCT is showing a huge PED with subretinal fluid, as you described, and 3 months later, it's barely visible. There's just you can see that very slight.
Yeah.
Wow. That's very interesting. Very interesting.
Yeah.
So,
and that's without any anti-VEGF.
yeah, right. That's remarkable. Wow. Wow.
So we're now engaging in another paradigm shift, the development of a safe, effective, and affordable device for patients to use in the comfort of their homes without the need to travel to clinics for what may be multiple and expensive sessions of PBM therapy. I also feel that the increased frequency of home use is an advantage compared to intermittent clinic visits, an analogy being of having an intense workout followed by months of no exercise, as opposed to small frequent amount of exercise on a continual basis. There may also be a benefit of frequent exposure to red light, given our environmental lack of red light. And over here, anyway, the very gloomy and short winter days, to counteract this imbalance. I consider this a form of preventative wellness. Eye care professionals can recommend and implement home-based treatment to patients, but still continue to monitor and be involved in the benefits of follow-up visits. All my previous patients were extremely grateful and appreciative to being offered PBM therapy when there were no other treatments available.
That the weather is pretty similar in Vancouver compared to London. So,
Yes.
we definitely can, for those of us on the West Coast anyway, we can relate.
Yes.
We can.
Yeah.
And I like
I'm
that.
kind of missing those those sort of wintry sunshine days in Toronto over here now.
Yeah, right. Different on the eastern side of Canada for sure. And I like that analogy of the frequent little bits of exercise versus, one big bout and then nothing else for a long time. That's I
Yeah.
think that's a very relevant analogy.
Yeah, seems to make sense.
Yeah.
So the device that is this paradigm shift is the Arunalight. It's lightweight, comfortable to use. Treatment is just 3 minutes, alternate days, best used in the mornings. There are 26 red LEDs covering the ocular area with a modest irradiance of 45 milliwatts per centimeter squared. And this is well within ocular radiation safety standards. It's recommended and advised to use this with eyes closed because it's more comfortable and relaxing, especially if you're looking at a fairly bright light. Lisa Ostrin from the University of Texas, who described retinal damage from a laser device used for myopia treatment in China, evaluated the Arunalight and determined that it would also be well within the safety parameters, even with open eyes. So, it's a very safe device. It was developed by experts in PBM, optometrists, and ophthalmologists with years of combined experience, really to provide a novel device for ocular use that eye practitioners can feel safe to recommend. It's the first PBM device to obtain Health Canada approval as a Class 2 medical device for ocular use, facilitating blood flow. And this is a major achievement, as obtaining this kind of approval is very difficult. Mm-hmm. The Arunalight is also CE marked in Europe and has FDA wellness clearance. And these are some of the eye diseases where there is clinical evidence of modifying and improving outcomes. A PBM is now proven in dry AMD and FDA approved. But I think there's potential to use PBM as an adjunct treatment to the standard of care anti-VEGF injections in wet AMD. lowering the frequency and increasing the interval of intraocular injections for wet AMD and also edema in diabetic retinopathy would provide huge benefits for patients and the cost of healthcare funded interventions. I've used the Arunalight for my own background diabetic retinopathy. And a recent screening exam, there was no retinopathy reported. Yeah, I'm very pleased to state that. Glaucoma, dry eyes, RP, corneal healing, optic nerve disorders, amblyopia, myopia, and ocular inflammation are all conditions where it has been shown to be of benefit.
Yeah, I'm hearing more about red light. So we're a fairly we do a lot of myopia control in our offices, and I'm hearing more and more about the potential use for red light therapy in myopia. So I'm very interested. Sadly, I'm hearing on your last slide you were mentioning about some potentially laser damage to children's eyes who were put into trials.
Yeah, so we're one of the, I think red light is potentially very good for myopia treatment. However, I fail to see, why you would need to use a laser directed on the fovea, and fixate on it as a child.
Yeah, that sounds like a.
It's just inherently hazardous to me.
Yeah, not great. Well, thankfully, hopefully they're not doing those trials anymore, and hopefully red light was beneficial to them after the fact, and I'll be excited to see how it helps us treat our myopic patients in the future.
Yes, I think so. I think it's a huge potential for that. So, talk about some of the different things that you could use it for. This is an example courtesy of Dr. Daljit Singh in India, utilizing a 670 nanometer PBM device for toxic optic neuritis. And he described dramatic visual recovery within several days. And the field tests that he was able to perform on this patient are in the next slide. And this shows a remarkable clearing of his visual fields with just 15 days of daily 670 nanometer PBM.
Holy moly. So this was a patient who had toxic optic neuropathy.
Alcoholic,
alcohol-induced. And the slide shows here on the left side, pre-PBM, the visual field is essentially just black completely in both eyes. Except for like a very faint central, maybe, and 6 days post PBM, what would you say, 75% cleared up, and then 15 days post, almost entirely cleared up. That's remarkable. Wow.
Yeah, and his vision improved dramatically.
Wow.
From hand movements essentially to.
Yeah. Goodness.
So this is again an example of some field changes in a glaucoma patient following 617 nanometers PBM, and although not so dramatic as the last slide, if we go to the next one as well, it does show some clearing of the visual field.
Yeah, and they improved in the VAs as well.
I think they were stable.
Oh, I see.
Yeah, I think the VAs were just stable and pressures were stable.
Maybe 2030 to 2025, 2020, there's a little bit of an improvement.
Yeah, a little bit of an improvement. Yeah, 2020 on the last one. Yeah. And I'm going to finish with this picture. This is the Great Wave. To me, this represents where we are with PBM in medicine. And I'd urge you to all join in this rising tsunami for the benefit of yourselves and your patients. I think together we can realize another true paradigm shift. Optometrists really should own this innovative, highly disruptive technology. It is a safe, effective, proactive, preventative, and treatment modality, which was within your scope of practice. It's ideally and easily suited for you to adopt in your clinics.
Very nice. And I love that image, that painting, that tidal wave.
Yes.
It seems like I would agree. It seems that this new technology, it's an entirely new area of investigation is likely going to change eye care, optometry, ophthalmology, and the way we treat. after you listed all those potential patients, you know, the diabetic retinopathy, glaucoma, of course, AMD, potentially myopia, that's most of the patients we're seeing on a daily basis.
Yes,
So
exactly.
yeah, so really remarkable. Well, first of all, thank you for that presentation, Dr.
Well,
Merry.
thank you for
Um,
allowing me to present it.
my pleasure. And I wonder, you know, to kind of wrap it all up, if there's any kind of discussion points that you wanted to make or reiterate. I had a couple of little questions or highlights that I wanted. We touched on a couple as we were going through it, but um, you know, I found that the look, one of the questions I had from the beginning actually that I wanted to ask you, and you went through it, was how do you obtain that FDA approval, Health Canada approval? But you outlined it actually. It's very interesting. You started with off-label use of somebody else's device. Then you said, okay, well, this is what I think worked. Create your own device, and then you have to define what the device is actually doing, right? So there's some sort of definition and parameters and protocols. That seems like a lot of work. And how did you
It,
come up with all of that?
it is. So, you know, when I met Dr. Dodson, he's really an inspiration and my mentor, if you like, in all of this. And he'd been using different red light devices in his clinical practice. He'd been using them post-surgery, cataract surgery, increased, you know, healing times. Been using them for all sorts of things. And we really sort of sat down and we thought, well, you know, how can we really try and move this forwards? And we decided that dry AMD would be a good target disease because there's nothing out there for dry AMD apart from there's no active treatments. There's
Right.
you know vitamins and lifestyle changes, and so that's what we initially looked at, and we used off-label devices. Just based on the evidence that we'd seen, you know, so basically red light, and you know, we got the good results. And once you get case studies and good results, you know, that would sort of lead you to want to prove this to a regulatory body such as the FDA, and to do that in a specific eye disease costs millions.
Yeah. I bet.
And so Lumithera, which we both co-founded, you know, raised a lot of money to do these kind of clinical trials.
I see. Well,
And,
that's
and
a part of it that we don't know about, we don't see. You know, it's like,
yes,
what did it
yeah.
take
No, it's very expensive. I mean, it's prohibitively expensive if you
to?
were sort of sitting there thinking, oh yeah, I'm going to use it. Well, let's just take, for example, myopia or something like that. You know, you'd have to develop a device and then, you know, have it approved and marketed. But I think with red light therapy, it's very safe. So, you know, from a safety point of view, I can't think of anything safer.
Yeah. Wow. I appreciated that actually in the earlier part of that the presentation, the differentiation between a laser and red light LED, because
Yes.
that's something even I wasn't totally aware of. But the coherent wavelength
Yeah.
versus the incoherent, and that the area, of course, that's dispersed over, that all helps to understand why red light is safer than lasers.
Yeah, well, I mean, lasers are red light as well. It's just
Right.
the irradiance is so much higher.
Yeah.
And one of the reasons that lasers are quite popular in different fields, say in you know pain and wound healing and things like that, is that they actually penetrate through tissue
Hmm.
better than an LED would,
I see.
because there's more intense energy there. But that's not necessary in the eye.
Right. Yeah, that's excellent. I think the other point of, you know, seems like at least one of the most well understood parts of why red light therapy works is the effect on the mitochondria, and that there is the highest concentration of mitochondria in the eye
Yeah.
versus any other part of the body. So that just intuitively makes sense as well.
Yes, it
Um,
does.
and given the eye is such a small structure and generally thin structure, I just, again, I'm assuming that the red light penetrates a little bit better than it would through other structures of the body. Is that correct?
Yeah. Yes. Well, red light actually penetrates quite well through the closed eyelids,
Mm,
but some other wavelengths wouldn't. You know,
right.
so some of the shorter wavelengths are actually that they won't penetrate
Got it.
nearly as
So
far.
more of a property of red light versus that.
Yeah,
That's
and you see, infrared light, near infrared light being used as well because there's more penetration. So for say, mood, using it for mood depression,
right.
using it in Parkinson's, Alzheimer's.
Wow.
It's more likely to be there's more likely to be a kind of infrared component because of
Right.
that penetrating effect.
Penetration. Got you.
Yeah.
Makes sense.
Well, I think
Well,
there's a
Dr. Mary,
potential for even red light
yeah,
eyeglasses to affect mentation as well. I mean,
right.
after all, the eye is just a direct extension of the brain.
Of course, as we know. Yeah, absolutely. What it's just remarkable to hear, and it seems in a way sort of it's just light. It's how we have we not come to this conclusion sooner. I know the conversation of red light has been around for a long time, but I guess like you're saying, it's prohibitively expensive to actually develop and get approval for these devices, even though it seems simple enough that it's just light.
Yeah, but there's a lot more to it than that
Of
as
course,
well.
I know. I apologize for
Yeah,
oversimplifying.
no, but no, you're quite right. And light has been used for centuries.
Yeah, absolutely. So, what would you suggest now, optometrists like myself, practice owner? How can I start to help my patients? What's the best next step for me?
Well, I think really what I would do and what I did really was obtain a red light, and patients may obtain them themselves as well. If there's especially if it's something that is so safe,
Hmm.
but to recommend these to your patients and really perform sort of case studies, if you like, even 2 or 3 patients, say with glaucoma, that hasn't been responding that well. Try them with some red light and see what happens. I
Yeah.
mean, you really got not much to lose.
Yeah, fair. That definitely seems to be true based on all the results that you showed us there. Downside is minimal,
Yeah.
where the upside is quite significant potentially. The Arunalight, is this a product that patients would purchase from our office and take home
Yes,
and use at
yes.
home?
I think there's a number of ways they could purchase it. They could purchase it directly. I think what we would like to do, certainly, in the beginning, is have some kind of eye practitioner control over it, or at least
Mm.
input into it. And I think that's going to benefit patients. It's going to benefit you as well.
Yeah.
They're going to be
Is
pretty happy.
is there a way that we would do this in clinic, or simply this is an at-home treatment?
No, it was designed really as an at-home treatment, because the thing I find about in-clinic treatments is they're going to be time-consuming, staff-consuming. Patients don't really want to come and visit a clinic every second day to
Right. That's a lot. Yeah, every second day is a lot. Absolutely.
yeah. Well, even in the LIGHTSITE trials, I mean, patients would do it because they're very motivated to adhere to the protocols, but
Mhm.
just think of all these patients getting injections and things like that.
That's true.
They've got to make a trip every month or 6 weeks. So,
For
yeah,
something very invasive.
yeah. And
Yeah.
so I think the best way really is to have the patient take it home with them, use it at home, and you do your follow-ups.
Yeah, great. All right, Dr. Mary, if our listeners wanted to learn more, where would they go for that?
Yeah, so I've got one last slide. I've got my
Oh, yeah.
email address on it.
Okay.
So if you wanted to pop that up, so it's my personal email. It's gfmerry@gmail.com.
I lost the presentation. I apologize. We'll just
Okay, all
we'll
right.
just do it this way.
So my email is gfmerry, MERRY, @gmail.com.
Got it.
And they could also look at the Arunalight website. There's a whole library of scientific articles on that site. We've tried to keep it up to date, and we've got some of the latest papers and
Great.
on there, and not just on the eye. We've got some sort of wellness papers and mood, brain. Yeah.
Yeah. And I
Well,
think there's an appetite for that, even just within optometry, within eye care, to learn about those other benefits, beyond the eyes, because it's such an intriguing area of discovery in medicine that I think we all want to learn about that. The other just overall benefits that could come from it.
Yeah. So that's www.arunalight.com.
Right. Arunalight. So ARUNALIGHT. Got it.
Yeah.
Arunalight.com. Excellent. Dr. Merry, anything else that you'd like to mention that we haven't talked about yet?
No, I think we're well on the way to really getting this into the hands of the people who need it.
Yeah.
And is going to derive great benefits.
Wonderful. Thanks again for joining me, Dr. Merry. I appreciate that. Really, really insightful. And I appreciate you with putting up with me with the technical difficulties.
No, I appreciate you putting up with me.
That's no problem at all. And thank you to everybody who's listening and watching the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys in the next episode.